A worrying potassium level. Scenario: a previously fit 74-year-old man presents to his GP after feeling unwell for 4 weeks with anorexia and more recently nausea, vomiting and breathlessness. He is found to have crackles at both lung bases and a grossly enlarged bladder. He is referred to the surgical admissions unit where blood tests identify renal failure, Na plus 134 mol/L, K plus 8.9 mol/L, urea 72 mol/L and creatinine 1208 mol/L. A urinary catheter is inserted. You are called to give an urgent medical opinion. Introduction. What should you check immediately? NB. This patient has severe hyperkalemia, a life-threatening complication of renal failure that requires urgent treatment. An ECG should be performed immediately and treatment should be instituted without delay, before an extensive history-taking or full examination. Assessment of severity of hyperkalemia. The main risk of hyperkalemia is cardiac arrest, and the ECG is the best guide of the severity of hyperkalemic toxicity. There are progressive ECG changes as serum potassium rises, first, tenting of T waves, followed by diminished P waves with lengthening of the PR interval and broadened QRS complexes, and finally a sine wave pattern. Before the onset of either asystole or ventricular fibrillation. This patient's ECG showed a sine wave pattern, Fig 6a, requiring immediate treatment. Treatment of hyperkalemia. Treatments for hyperkalemia are shown in Table 5. Severe ECG changes. Calcium counteracts the cardiotoxicity of hyperkalemia by stabilizing the myocardium. It acts as soon as it reaches the heart, and its effect lasts for about 1 hour. It should be given intravenously in 10 ml aliquots and repeated as necessary until the ECG improves significantly, Fig 6b. Calcium does not affect serum potassium concentration. After calcium, give insulin and dextrose or nebulized beta agonist. They do not have an additive effect. Either of these should lower serum potassium by about 1.5 mol/L within 1 to 2 hours. The effects of calcium and of insulin and dextrose will last for 3 or 4 hours, unless the patient has a form of renal failure that is likely to recover quickly, as might be possible in this case with the relief of obstruction. Use this time to arrange transfer to renal/intensive care unit, ICU, services for dialysis/hemofiltration. NB. If the ECG shows severe changes of hyperkalemia, tented T waves with diminished P waves or broadened QRS complexes, give intravenous calcium immediately. Less severe ECG changes. If the only ECG manifestation of hyperkalemia is tenting of T waves, then it is not necessary to give intravenous calcium. Give insulin and dextrose or nebulized beta agonist. Note that none of the treatments mentioned above actually remove potassium from the body. This can be accomplished by renal excretion, if kidney function can be restored, by dialysis or to a limited degree by ion exchange resins. In obstructive nephropathy, relief of the obstruction will often lead to an immediate diuresis with potassium removal, but when hyperkalemia is severe then dialysis will often be necessary. What else should you check? The man is breathless, most likely due to pulmonary edema, so before embarking on details of history and examination, make sure that he does not require urgent attention for this. Check his airway, breathing and circulation, which of the 4 categories, well, ill, very ill or nearly dead, describes the patient. If nearly dead, call for ICU help immediately, don't wait for cardiac arrest. After this, note the following. Can he talk? If so, how many words at a time? Is he using his accessory muscles to breathe? Is he exhausted? Cyanosis. Vital signs: pulse rate, respiratory rate. Beware the patient with a normal respiratory rate who is exhausted, as death may occur soon. NBP. Peripheries: are they cold and shut down? Cardiac examination, JVP, likely to be grossly elevated, and gallop rhythm. Chest examination, crackles or wheeze. If the patient is very ill or worse, sit the patient upright, assuming that pulmonary edema and not hypotension is the main problem. Give high-flow oxygen via reservoir bag. Attach pulse oximeter, to monitor oxygen saturation. Connect to cardiac monitor. Establish intravenous access. What are the likely diagnoses in this patient? The combination of renal failure with clinical evidence of urinary retention is usually the result of long-standing bladder outflow obstruction. This is most often caused by benign prostatic hypertrophy, although other possibilities should be considered. Table 6. Bladder outflow obstruction with renal failure is a common clinical scenario, accounting for up to 30% of cases of acute renal failure in community-based studies. In such cases there is often a long history of urinary outflow symptoms and presentation is notoriously late. History of the presenting problem. After immediate treatment for hyperkaliemia and pulmonary edema has been given, take a full history concentrating on the following. Symptoms relating to renal failure. There is often a nonspecific prodrome with malaise, fatigue, and sometimes nausea. As renal failure advances, these rapidly progress with the development of vomiting, confusion and eventually coma. Symptoms related to urinary outflow obstruction. Chronic retention is usually painless, in contrast to the restless agony of acute retention. Ask about frequency, most common and earliest symptom, urgency, and difficulty with micturition, poor stream. Symptoms related to specific pathology. If obstruction is caused by a pathology other than benign prostatic hypertrophy, then specific symptoms may be reported. Prostate or bladder malignancy may be indicated by loss of weight, hematuria, or bone pain. Although almost certainly not the explanation in this man, kidney/bladder stones may be a problem in others. Symptoms related to infection. Urinary tract infection is present in at least 50% of patients presenting with renal failure caused by bladder outflow obstruction. Examination. General features. Before you started to take a history, you rightly made a general assessment of this patient and initiated any necessary emergency treatment. Abdominal system. When the patient's condition permits, look for evidence of causal pathologies, see Table 6, especially the following. Lymphadenopathy and hepatomegaly, suggesting malignancy. Rectal examination, benign prostatic hyperplasia or malignancy. Neurological signs in the legs, this is unlikely to be bladder outflow obstruction resulting from spinal cord pathology, but it is a bad mistake to miss it. Record the residual urine volume from catheterization and the rate of urine output. Investigations. NB. If available, past biochemistry results indicate the chronicity of renal damage and the level of recovery to expect. Check the notes, check the pathology records, and ask the GP. Blood tests. Repeat electrolytes and renal function. FBC. Clotting screen. Liver and bone function tests. Prostate-specific antigen. Blood cultures, if suspicion of sepsis. CXR. To assess for pulmonary edema, and also, although much less likely, for secondaries in lungs or bones. Ultrasonography of urinary tract. This is required urgently in any patient with an unexplained acute deterioration in renal function. A large residual bladder volume in combination with bilateral hydronephrosis, Fig. 7, is diagnostic of obstructive nephropathy caused by bladder outflow obstruction. Management. Pulmonary edema. The spectrum ranges from mild breathlessness on exertion to respiratory failure leading to respiratory arrest. All patients should receive high-flow oxygen and be set upright. Those who are severely compromised with increasing respiratory rate, fatigue, and hypoxia require transfer to the ICU and, probably, ventilation. In others, intravenous nitrates may be sufficient until fluid can be removed by either diuresis, perhaps after relief of obstruction in this case, or dialysis with fluid removal by ultrafiltration. Hyperkalemia and fluid overload causing pulmonary edema are the most common indications for urgent dialysis, others are given in Table 7. Volume depletion and fluid replacement. Although this man's initial problem is pulmonary edema, relief of obstructive nephropathy is often followed by excessive diuresis associated with sodium, potassium, bicarbonate, calcium, and magnesium wasting. This happens because the tubules have forgotten how to concentrate the urine and thus there is a risk of the patient becoming volume depleted, which could compromise recovering renal function. Note the following. Fluid status, postural hypotension, JVP, and weight, and biochemistry should be checked frequently, usually daily. Care needs to be taken with the sodium content of intravenous fluid, alternating physiological, 0.9%, saline and 5% dextrose is usually an appropriate choice. Large quantities of potassium may need to be given, 20 to 40 mol/L, this requires close monitoring. It is sometimes helpful to measure urine biochemistry to determine the specific losses. If the patient is polyuric and passing more than 3 L of urine daily, give a total fluid input equal to the measured output of the day before. This will achieve a gentle negative balance. You will need to monitor volume status carefully. NB. Don't chase your own tail. Avoid driving a post-obstructive diuresis with huge volumes of replacement fluid. If urine output does not continue, the urethral catheter has drained the bladder, but there may be coincident ureteric obstruction. This is particularly common in prostate carcinoma, which can spread to encase the ureters. Repeat ultrasonography to determine whether the hydronephrosis has been relieved. Consider CT to look at the retroperitoneum and involve the urology team. Other possibilities are that the kidneys may have been chronically damaged by obstruction, or there may be acute tubular necrosis resulting from the combination of hypoxia, sepsis, and poor perfusion. Also consider other causes of renal failure. How convincing was the evidence of obstruction and what was the residual urine volume?